morning. Welcome back to Open Med School. In the last sessions, we have discussed on GBS, the pathogenesis, and clinical manifestations, general support, and the immunotherapy. Today, I'll be discussing about the prognosis, relapse, and the variants of GBS. So, we are all aware that there are different types of GBS, and the pathogenesis we have explained. I'll just go through a recap. The most common type is the AIDP. There is a preceding infection like Campylobacter, CMV. In AIDP, there will be cell-mediated T cell and macrophage produces attack on the Schwann cells and the myelin sheath. There is segmental demyelination characterized by conduction block, reflexia, and weakness. Whereas in AMAN, the motor axonal neuropathy, there is an anti-gangliocyte antibodies like anti-GM1, GD1A bind to gangliocytes on the motor axonal and complement-mediated activation at the nodes of Ranvier leading on to axonal degeneration. So these are the two fundamental points you should remember. That is in AIDP, it is T cell macrophage induced demyelination. And in AMAN, it is anti-gangliocyte producing damage to the axilla and axons are damaged. And now we go into what are the major subtypes. Again, here you can see that majority, around 52%, it is AIDP. So AIDP is a predominant variety. AMAN constitutes only 26%, AMSAN 7%, and some are unclassified. And Miller-Fisher syndrome is 7%. So this is the split up of various types of this GBS. Now we go into the long-term rehabilitation and recovery. Recovery of GBS begins within 2 to 4 weeks after progression. So this is something that you should keep in mind. That is the disease will. So suppose you draw a graph. They can progress for 4 weeks. Then there's a plateau phase. Then the patient goes to recovery. So this is what is usually happening in GBS. Hope this point is clear to you. So in the GBS patient, the recovery starts 2 to 4 weeks after progression stops. So that is what I have told, a plateau phase. So then 2 to 4 weeks are taken for progression stops, and then the improvement may occur through months to years. Our rehabilitation goals are to prevent contractures, deconditioning, improve motor strength, to treat the neuropathic pain, address the autonomic symptoms present like bladder dysfunction, and psychosocial well-being. Early physiotherapy is important. It will improve the functional outcome of the patient. It should be a multidisciplinary approach, including neurology, physical medicine department, occupational therapy, psychology, and social work. What are the potential long-term effects? Fatigue is one of the most common symptoms. And residual weakness can occur in significant percent, around 17%, some residual dysfunction. Chronic pain is common, autonomic dysfunction sometimes, and psychological distress, that is something that you should always keep in mind. So the most common problem is persistent fatigue. Residual weakness can remain in 10 to 20% of patients, and aches and pains are common. They are deep aching, especially in calf muscles and back. Orthostatic hypertension and bladder issues are present. Post-traumatic stress disorder related to the ICU, anxiety, and depression also needs to be taken care of. Fatigue may persist even when the strength recovers, and this is often the most disabling symptom. But there is one thing you should keep in mind: the fatigue can persist for long, and this may be a persistent symptom even if the patient recovers. So what are the prognosis and relapse? 85 to 90% of patients recover the ability to walk independently 6 months to 1 year. That is a good thing to remember. Better prognosis is in younger patient, shorter time to treatment, mild to moderate weakness, and demyelinating subtype. So AIDP is having a better prognosis than AMAN and other subtypes. The poor prognosis, old age, delay in therapy, rapid progression, severe axonal injury, AMAN, and need for prolonged ventilation. These are the things that you keep in mind when you think about the prognosis. So let us look into the recovery pattern. This is from one study. Full recovery occurred in 25% and a good recovery in 61%, and residual weakness occurred in 14%. So that is about the long-term prognosis. Now the question is, can GBS get a relapse? Relapse occurs in 5 to 10% of patients after improvement. It occurs usually within the first 2 months, requires repeat immunotherapy, and it has to be differentiated from CIDP. So what is CIDP? CIDP versus GBS. The CIDP, the GBS is a acute in onset. It is relapsing, usually monophasic. Good response to IVIG and PLEX. Maintenance therapy is not required. Whereas CIDP, is a chronic, usually more than 8 weeks, progressing. Some relapse can occur. Many long-day therapy, including steroids. So that is regarding the. Now we look into the variants of GBS. All weakness are not alike. The most important one you should remember is the Miller-Fisher variant. So Miller-Fisher variant is characterized by ophthalmoplegia, ataxia, and reflexia, often without limb weakness. May present with the diplopia, imbalance, and absent reflexes. The important thing to remember is there is an anti-GQ1 antibody. So the characteristic antibody response is anti-GQ1 antibody in GBS, the Miller-Fisher. Second important variant is AMAN acute motor axonal neuropathy. It's a pure motor syndrome, more common in Asia, China, Latin America, often follows Campylobacter infection. Rapid and severe motor weakness often requires ventilation. The characteristic antibody is anti-GM1 antibodies. Recovery in AMAN may be prolonged and incomplete due to axonal degeneration. So, prognosis is bad. Then comes the acute motor sensory axonal neuropathy, otherwise called AMSAN. There is an acute motor sensory axonal neuropathy. It's a rare, it's a severe variant. Motor and sensory fibers are affected, slower recovery. That is the third variant. And another important and interesting variant is the pharyngeal cervical brachial variant. So we already said that the GBS is usually an ascending paralysis. Here it can affect the first as the pharyngeal and cervical muscles, and weakness is restricted to oropharyngeal, neck, and proximal upper limb muscles. Reflexes may be preserved in the legs. It is associated with the anti-GT1A antibodies. So now go into the variants and the antibodies. Miller-Fisher, it is anti-GQ1 antibody. AMAN, it is anti-GM1, and pharyngeocervical brachial variant, it is anti-GT1A antibodies. Hope it is clear to you. Now the key messages are rehabilitation is critical for GBS. Most recover fully. Fatigue is not important symptoms that may persist. 17% can have weakness. GBS variants have distinct features and distinct antibody profiles. GBS recovery is slow, steady return of functions. So that is the important point to be remembered. Hope this was useful to you. Stay tuned. Thank you.